You'll have to unmute yourself in order to tell us about you.
Oh, sorry. I was just getting my audio figured out. I'm Patrick. I am, I guess, between my second and third year doing a master's in research at Oregon Health and Science University. Have not
Great.
done any clinical rotations yet.
Good. If you feel overwhelmed at any point, it's okay. And if we say anything that doesn't make sense, make us explain it.
All right.
That is good form in this. We want you when you get to the wards to be just a little bit smarter than you are right now. Rebecca, why don't you introduce yourself?
Great. Thank you guys for having me. I'm Rebecca Berger. I am a attending hospitalist at New York Presbyterian Cornell in New York City. I haven't discussed on unRemarkable Labs yet. I've been listening for the last few weeks. And I think what I like so much about it is that it reflects what I actually do on a day-to-day basis when I'm, seeing new patients or often following up on patients, in the hospital, which is that, for better or worse in today's, era, I'm often looking at the data first. And I think required to start constructing a differential diagnosis, around the data before I've sometimes even met the patient. So it's good
one
exercise.
Of the reasons for this. Carl, why don't you introduce yourself?
Yeah, hey everyone, my name is Carl Zainaldin. I'm actually an intern here at UAB, categorical medicine intern, and yeah, right now this is an exciting case I'm happy to present today that is definitely a good internal medicine case, and I'm excited to share it with you all.
Great. Are we recording? Yes. We are recording. Okay, Carl, go ahead. Give them the BNP and then tell them the story. This is actually going to be a long story, so we're not even going to worry about the BNP because it has to be in the context of the story.
Mm-hmm. Yes. So I'll tell you all about this patient. This is a 62-year-old male with a past medical history of coronary artery disease, heart failure, hypertension, CKD stage 3, and peripheral vascular disease, who initially presented to the hospital as a transfer from an outside hospital with CT scan showing occlusion of the abdominal aorta just below the renal arteries, leading to bilateral lower extremity critical limb ischemia. So a complicated medical history and definitely a lot of vascular disease going on. So he was admitted and he underwent successful right axial bifemoral bypass surgery about 3 weeks before we accepted this transfer. So before accepting this transfer, his hospital course, the surgery was successful, but hospital course was complicated by an AKI. So renal and cardiology were both following. Cardiology more for his heart failure history and medical optimization around the surgery time. And he was actually ready to discharge from the surgical service. They were ready to send him home when his creatinine increased, developed an AKI. So they called us on a Friday and said, will you all accept this patient for further workup?
If this has never happened to you, it will. Yeah. I don't know why these transfers always occur on Fridays, he said somewhat cynically. Okay, so let's show them the numbers that we had at the time.
All right. So the BNP sodium was 130, potassium 4.9, chloride 95, bicarb 22, And then BUN 59. And creatinine was 2.9. Glucose was 89.
Okay, Patrick. This is what we do every day.
All
We
right.
look at these numbers and we stare at them. Had you seen the fishbone before?
Yes.
Good. So you were at least familiar with that, because some students coming into the third year are not that familiar with it. So just do the best you can. What are you thinking? And then we're going to let Rebecca chime in, teach a little something, and then I'll probably chime in and be fairly antagonistic.
Okay, so he's hyponatremic, but not by much, which is not very surprising given that he has heart failure. Potassium is like upper range of normal, but he has CKD, so again, not surprising. He doesn't have any sort of gap, doesn't have an abnormality in the bicarb or the glucose, and then we get to what really seems to be going on with him, which is as creatinine is elevated and his BUN is also elevated about 20 times the creatinine. So I think most AKIs are pre-renal, which, you know, having a high BUN would be consistent with, but then a couple things that could cause kidney injury in this scenario. I imagine if you have critical limb ischemia, you could get rhabdo later, but then also sort of messing around with the infrarenal aorta, I think you can compromise the blood supply to the kidneys. And I guess if something went really bad, there could be like a spinal cord injury and like a
So
progenic uropathy. I don't know the term.
So the good thing is he's moving around and asking to be discharged.
Okay.
He's moving
Good
around
point
asking to be
for that.
discharged. And we're nervous about the BUN and creatinine. 130 could be heart failure. The important thing to know about 130 is that it pretty much tells you the patient is sick, but it doesn't say what the patient's sick from. So it's sort of it's almost a sign of inflammation, because ADH is probably being released, especially when they've been in the hospital for a while. So here's the first thing that you should have, that you want us to do when you get on the wards, is say, what was his creatinine when he came in the hospital? Because we don't know what 2.9 means. If he came in at 2.9, then this is bogus. Do we know what it was, Carl?
Yeah, his baseline creatinine over the past year was 1.8, and it was right at that. It was 1.9 on admission. So he was right at base.
So that's a tip, Patrick, that you always want to know where you came from. Rebecca, what do you have to add?
Excellent. Patrick, that was excellent. I will happily accept you as my student and intern any day. Thank you for that. So I agree with everything you guys have said so far about most of the BNP. I think since the most remarkable part is the BUN and creatinine, I think I'll focus on that. You know, I think we often jump quickly to thinking that an elevated creatinine is a reflection of AKI or a reduction in GFR, but I think it's important first just to think about whether there could be a kind of false positive, essentially, something that reflects an increased creatinine without a decrease in GFR. So examples of that would be like rhabdo, like Patrick, as you said, so increased production of creatinine in the body. And then certain medications can also, you know, decrease creatinine secretion. So the most famous of which would be trimethoprim sulfamethoxazole. But I think there's other meds that can do it. But if those things are thought to be less likely by reviewing the med list and maybe checking a CK, or I guess, you know, the fact that he's up and walking around and doesn't have any reason to have had rhabdo is probably enough to rule that out clinically, you know, then we have to think about kind of our standard framework for thinking about AKI or reduction in GFR. and Patrick, as you said, I think most AKI that we see in hospitalized patients is pre-renal. But I think we of course have to think about obstructive disease, and then we have to think about intrarenal processes. And, the benefit of someone having been in the hospital for this long is that we have a lot of data. And so, to think about pre-renal etiologies, depending on how sick or how well he is, we may or may not have good data tracking on intake and output. We may have weights over the last few weeks. I think you said he was hospitalized for a full 3 weeks right before he came to us. So that's kind of looking for pre-renal azotemia in terms of total body fluid. Although, of course, in a patient who has heart failure, we also have to think about a kind of cardiorenal syndrome, so a decreased effective circulating blood volume, are the kidneys not seeing enough perfusion? So what we didn't hear was anything about his heart failure specifically. So does he have a reduced ejection fraction or a preserved ejection fraction? Has he had any reason to have, accumulated fluid over the course of his hospitalization? Sometimes people are getting a lot of fluids or blood products, before surgery. So we want to think about his volume status, both being kind of total body overloaded or depleted, could be contributing to this. In terms of obstructive etiologies, we didn't hear about a history of prostate disease, although that would be the most common in this patient. And in terms of his demographic, otherwise we'd have to think about something compressing the bilateral ureters, which, typically is less likely, but something we have to think about. And then of course, the kind of big black box of intrarenal pathologies. So, in the case of a hospitalized patients, medications causing ATN is definitely one of the biggest offenders. But again, thankfully here we'll have a lot of data, hopefully, either through the medical records that they sent over or through a phone call, so that they can, look through all the meds he's gotten, to think about antibiotics, to think about, other medications that can be nephrotoxic. And then, the other probably most common thing in the hospital that causes ATN is hypotension or decreased perfusion. So, asking them for a trajectory of blood pressures over the last several days. Contrast is a little bit of a controversial topic, I think, in AKI these days, and whether it really matters or not. I think I think arterial contrast may still play a role. So I assume that at some point he had an arteriogram, given his bilateral ischemia. But if it was pre-surgery 3 weeks ago, it may not be the cause of his AKI right now. It'd be helpful to know not only what that creatinine was on admission, that 1.8, but also whether it has crept up over the last 3 weeks, or whether it was kind of 1.8, 1.9, and then all of a sudden jumped the day before admission. So those are some of my initial thoughts.
You guys are doing great. I'm gonna give you my bias. I hate the term AKI because it has the word injury in it. And both of you were spot on in saying, is this injury, or is this pre-renal, or is this post-renal? And so AKI is sort of the shorthand for the creatinine went up. And I understand why they did it, but we make mistakes if we don't think the way that y'all have actively thought through it, of trying to decide, is there really a kidney injury? Could it be the kidneys are working exactly the way they should work? And why we call that an acute kidney injury is just, it bothers my sense of semantics. We do have an echocardiogram. So Carl, could you let them know what the most recent echocardiogram showed?
Yeah, so he did have an echo performed preoperatively, and he had an EF of 30 to 35%, elevated left atrial pressures, regional wall motion abnormalities, and mild global hypokinesis of the left ventricle. I should also mention he had a PCI like 3 years ago, so that it kind of explained the wall motion abnormalities.
Patrick, let's let Patrick dig into the echo just briefly. What does this echo tell you?
So his ejection fraction is low. So this is basically heart failure with reduced ejection fraction. Elevated left atrial pressure is just secondary to, it's trying to push blood into a ventricle that's already full. And then the hypokinesis and regional wall motion abnormalities, I think, reflect like ischemic scar tissue.
Right. So anytime you see regional wall motion abnormalities, it's possible to get that without having an MI, but it's really hard. And so that's coronary artery disease until proven otherwise. Now, we already knew he had coronary artery disease, but if you just get that in a patient. So, Rebecca, what do you think about 30 to 35%? So you were worried about cardiorenal and all that type of jazz and how bad his heart failure is. What do you think when you see 30 to 35?
I think definitely at risk of cardiorenal disease for sure. You know, I've kind of seen it, to be honest, in all types of heart failure patients. I've definitely seen the kind of HFpEF patient who's 40 pounds above their dry weight who gets cardiorenal. And I've also seen the, you know, the patient with severe ischemic disease with an EF of 10% get cardiorenal. So I think, you know, in my clinical experience, I think any heart failure patient could surely develop cardiorenal syndrome. I think the volume status and the kind of ventricular give matter more.
And we really don't know, because the echo was before surgery, we really don't know where he stands now. What was cardiology's plan when we received the patient, Carl?
So when we received the patient, cardiology had been following, as I mentioned, primarily for medical optimization pre-surgery, and then after surgery, the patient was felt to be somewhat volume overloaded. He had been taking Lasix 40 milligrams daily at home. So he was actually diuresed with IV Lasix for a couple days before we received the patient. And our plan when we got him was to decrease the diuresis and basically in the setting of an AKI. And that's what cardiology had also recommended, to decrease diuresis.
So and what were they planning to do that next Monday?
Yeah, so next Monday, the physical exam, you know, the patient, as we mentioned, was moving around, looked pretty good. He did have some lower extremity edema, like 1+, but not a significant amount of JVD. So because his volume status is very difficult to tell, and sometimes on physical examination, it's challenging. And they wanted to do a right heart cath to basically get more information about his volume status and cardiac function.
So we watch him over the weekend. Nothing too exciting is happening over the weekend. We make rounds on Monday. I'm expecting him to go for his right heart cath. I check back in the afternoon, and what do you think Carl tells me? Carl, tell him what you told me.
Yeah, so before the right heart cath, you know, we check a PT INR, which hadn't been checked, I think, since admission. And his PT was 42 and INR was 3.8, which we were all quite surprised about.
Patrick, what do you do with that?
Is he taking warfarin?
No.
Okay.
He is taking an anticoagulant. So Carl, go ahead and give him that information, some medication information.
Yeah, so he was on, so another finding on the echo that I didn't mention was he had a known left ventricular apical thrombus, probably secondary to his MI a few years ago, and he was on Xarelto.
Okay. And that's like a low molecular weight heparin?
No. Okay, Rebecca, do you know which one? I can never remember. I know it's a DOAC. I don't know which one it is. Which one is it?
Rivaroxaban. It's a 10A inhibitor.
Yeah. Yeah. So this is the most confusing thing when you get on the wards, is people interchange generic and trade names, and you have no idea what the hell they're talking about. And then when you get to the test, it's all generic names. And so we're rude to medical students by throwing out the different names. Somebody wanted to know, Carl, whether we had tried to assess volume status with an ultrasound, bedside ultrasound.
So we did. We put an ultrasound probe on him and took a look at his IVC that was, it was actually collapsed, kind of to our surprise, collapsible with sniff. It's not completely collapsible, but probably about 50%. So we were expecting to see a kind of big dilated IVC, but we didn't. Yeah.
That sort of encouraged us to stop giving him diuretics at this point.
Yeah.
So now we got this pro time of 4, INR 4. Rebecca, what do you want to do?
Definitely surprising, it sounds like. I think many of us who take care of patients who are on DOACs typically see the INR elevated in the kind of 1.7, maybe 1.8 range for patients that are reliably taking their apixaban, rivaroxaban. Definitely would not expect to see a 3.8 from those medications alone. So I think definitely worried about potentially his liver, right? So is he making his coagulation factors? Could he be developing liver injury? In this case, maybe even acute liver failure. It doesn't sound like he has any evidence of encephalopathy, but coagulopathy would surely be concerning. So I'd love to know what his transaminases and his bilirubins look like, and to do, some encephalopathy testing.
And those also had not been checked for the entire hospitalization. Remember, he was being transferred from a non-internal medicine service. If he's on internal medicine, we would do it on, if you came in, we'd check every lab known to mankind.
And then the other question would be, is he developing some type of coagulopathy? So is he in, DIC or some other kind of thrombotic microangiopathy, which again could connect his kidney disease with coagulopathy? Has he developed an acquired, inhibitor of some kind of the coagulation cascade? So I think practically the way I would approach it would be first to make sure that this isn't a sign of impending liver failure, to check his platelets and, the other coags. You gave us a PT and an INR. Did we get a PTT also? So yeah, I would just make sure I've kind of assessed the entire kind of thrombosis and coagulation, kind of standard procedures, maybe even send a mixing study if there's no obvious culprit on that initial workup, and go from there.
So that's exactly what we did. So Carl, go ahead and give them more information.
All right. Yeah. So we checked his liver function tests, and the results of those showed that they were actually all elevated. So his AST was 545, ALT was 511, alk phos was 262, total bilirubin was 2.08, and then his total protein was 5.9, and albumin was 2.9. We also checked a hepatitis panel that was negative, and those were the initial lab tests that we performed.
And what's happening to his creatinine and his BMP at this time?
Yeah, so at this point, we had actually stopped diuresing him because of physical examination and bedside ultrasound findings, and his creatinine continued to increase. So by Monday, it went from, his creatinine was 2.9 on Friday. Now it's up to 4. His BUN went from 59 up to 8.2. And his other electrolytes were about stable. Bicarb decreased a little bit, but definitely worsening, increasing BUN and creatinine. Yeah.
So this is a really complicated case, Patrick. So you're really brave to jump in, but just tell us what you're thinking about. I'll see what Rebecca is thinking about, and I'll tell you what we were actually thinking about, because we had a Carl and I and our resident and our other intern had a long conversation about this.
So the LFTs, it looks like he has an indication of both like hepatocellular, the AST ALT elevation, and then biliary injury with the alk phos and T-bili elevation. And with the AST greater than ALT, I know that's often associated with like alcohol-induced hepatitis, but I think certainly the list is shorter.
Time out. We gotta teach you this right away, because you have the right instinct, but you got this one wrong, and we're gonna help you. Number one, you almost never see an AST above 300 from alcohol alone.
Okay.
Number two, it's not that the AST is greater than the ALT, it's that it's usually twice or more than the ALT. So this is minimal difference. This is essentially they're the same. That's within lab error.
Okay.
So that's the right instinct. I hope I wanted to give you information so that you don't do this in front of some attending on the wards when you get there, that you know this is not alcohol. And he's been in the hospital, he hadn't been drinking.
Right.
So why would you get so he clearly has elevated transaminases. You can explain away the alkaline phosphatase just from the swelling from the inflammation. It doesn't have to be two different things. It can be intrahepatic obstruction just from inflammation. So the inflammation is really strong, but the albumin is decreased. This is what Rebecca was concerned about. Is the protein, is the protime INR elevated because the patient's liver's not working well? And if the liver's not working well, what the two things that we measure that the liver as a factory is doing is the INR and the albumin, and they're both abnormally low. The INR is abnormally high because vitamin K is low and the albumin is low. So that, Rebecca, that sort of fits your theory, but why would this happen, Rebecca?
That's a great question. I think, assuming, and
We
this
spent a lot of
maybe-
time trying to figure it out.
It's a big assumption, but hopefully there's at least a set of LFTs from earlier in the admission, maybe not every day, like we check unnecessarily on the medicine services, but was there anything from initial admission?
I don't think so. Was there,
Okay.
Carl?
No,
Had
we
never
don't-
been checked.
Yeah. Mhm.
So I think it's unlikely that this is, that he's walking around, all the time for the last several years with, transaminases in the several hundreds. So if we were to make the assumption that he had normal transaminases on admission, he's developed some, interval hepatocellular injury in the hospital. And our first instinct, as you guys did, is to check hepatitis serologies, but I don't think that reactivation of viral hepatitis is the most common in the hospital. The thing that I see most commonly is actually medications as well. So we talked about antibiotics as a cause of ATN or AIN, but I've seen cephalosporins cause both cholestatic and hepatocellular liver injury. So I would definitely want to take, once again, a really good list of that medication. I'd want to think about with this degree of elevation, I think medications I always review, but I don't know that I've seen, transaminases this high with medications. So I'm starting to think about, decreased perfusion to the liver. So thinking about a clot,
Okay.
maybe that, that led to decreased perfusion. We already know that he's a clotting guy, right? He had that LV thrombosis. So, could he have developed a clot that decreased perfusion to his liver? Again, going through that blood pressure trend to make sure he didn't have a reason to have developed a, shock liver scenario. Classically that's going to be transaminases in the thousands, but these are getting there. We don't know their trajectory.
Well, so we thought of that, and I'm so happy you brought that up, because that's in our differential right now. And my thought was it could have been shock liver right after surgery, go up to the thousands, but now it's coming down. So we might be catching it on the downslip. We don't know if we're catching on the upslip or the downslope because we don't have any numbers. What else could cause these numbers that comes into play in his differential? So if he has shock liver, he could have shock kidney. So one of our theories was this is shock liver and shock kidney. And so we got to figure that out. But we had another really good hypothesis. So you mentioned cardiorenal. What would go along with cardiorenal in the liver?
Like a congestive hepatopathy.
So that we thought that was the main differential. Carl and I sat down and talked about it, and we came up with that as the differential. Now we have one more thing going for us. He's oliguric. So of course I asked for a urinalysis. He's never had a urinalysis. Never had a urinalysis. So you can imagine me going a little crazy. So what test should work in someone with an increasing creatinine and oliguria? So there are a lot of people who say that this is not a very useful thing, but the fractional excretion of sodium
We check
is
them
a
all the time and not.
absolute perfect test here.
Yep.
Absolute perfect test. Why? Because if it's either volume contraction or cardiorenal, it's going to be underperfused. The kidney's working normal. It's going to reabsorb sodium because it's trying to protect volume. Because the problem in cardiorenal is decreased forward flow, and the kidney thinks it's volume contracted because there's decreased arterial volume. If it's really a kidney injury, if it's ATN and ATN had to be in our differential now, then he's got to have a sky high fractional excretion of sodium. So it could be low with rhabdo, Paul says. But there's no evidence of rhabdo in this guy, and his CK was fine. So we're going to get those numbers, and then we're going to see what we do with those numbers. So let's get them the urinalysis first, Carl. So this all comes back the next day. We're holding his anticoagulation. We don't want to give him vitamin K because he's going to need to be anticoagulated. So we're really between a rock and a hard place with this proton. We could correct it, but then we couldn't get him. We might not be able to get him re-anticoagulated as well.
Yeah, so his urinalysis showed in the pertinent findings here, specific gravity was 1.015. His he had 2+ protein, 1+ blood, 2 urobilinogen, no concern for infection, and some hyaline casts. Then we also checked urine and creatinine.
Let's wait on that because I want to go through one at a time because we have enough time. So Patrick, have they taught you anything about urine specific gravity?
I think it's the last two numbers times 20.
Approximately.
Like your osmolarity?
Probably times 30. Approximately.
Okay.
But you have the right idea. So this is the simple way to think of it. 1010 is isothostanuric. That means the urine osmoles, the serum osmoles are the same. So 1010 is your breaking point. Above 1010, it's concentrated. Below 1010, it's dilute. It does not work after someone got a dye study. So if you get an admission from the ER and they already had a CT with dye, the specific gravity doesn't help you at all. In this case, we know he hadn't had dye anytime recently, so this suggests he's able to concentrate his urine. Does that help us? If that's the only thing we had, does that help us?
Yes.
Absolutely. So teach him, Rebecca. Does it help you? Rebecca?
It says he's got functioning tubules, right? He's
So,
filtering and he's got functioning tubules.
Right. And because some of you have heard this, the man who wrote the fractional excretion of sodium article was a renal attending at Medical College of Virginia, VCU, where Drew is right now, where I went to medical school. And the month after the article came out, he was my attending on the general medicine wards because in the 1970s, all the subspecialists attended on the general medicine service. It was very, very different time then. And he taught me all about the fractional excretion of sodium. So I got it because I was really curious. So go ahead, Carl, because this is spectacular.
So we checked his urine creatinine, which was 183, and his urine sodium was 7. And then that's comparing to, on the same day, BUN of 82 and creatinine of 4.2 and serum sodium of 131.
So I'm so glad that somebody mentioned that this could be glomerulonephritis. It's not glomerulonephritis, but you do get a low fractional excretion of sodium with glomerulonephritis because the tubules are working. And that's from an article from the group in Colorado in the 1970s. So if glomerulonephritis is in your differential, this does not distinguish from volume contraction. This is the lowest fractional excretion of sodium I've seen in my entire career. It's 0.1%. Now, I didn't need the urine sodium here. As soon as I saw the urine creatinine, I knew that his tubules were working real well. Does that make sense, Patrick? Or would you like me to explain it?
I mean, it's getting rid of creatinine appropriately, but I don't know how that tells you about the sodium.
So it's actually what it's doing, it means it's reabsorbing the water. So I want you to think about this. He has a creatinine, let's say he has a creatinine of 4, and let's say his urine creatinine was 200. How do you get from 4 to 200? You have to reabsorb a very high percentage, I think it's like 98% of the water that gets filtered in order to do that. So the urine to plasma creatinine ratio, once it's above 40, somewhere above 40, and his is like 45, that means that water is being reabsorbed very well, and the concentrating mechanisms are working. People with ATN, in my experience, mostly have urine to plasma creatinine ratios of 10 or less. Really, I'm talking about oliguric ATN. We couldn't really done this if he wasn't oliguric. If he wasn't oliguric, fractional excretion of sodium probably is not going to work as well. Now, what do you want to do? So now we know that his kidneys are working real well, and we know he has heart failure. We're suspicious that he has cardiorenal and congestive hepatopathy, because now we've sort of ruled out shock kidney. So if we ruled out shock kidney, the kidney gets injured faster than the liver gets injured. So we really don't believe he has shock liver. So what do you want to do? This is definitely a Rebecca question.
I think I'm struggling with the assessment of congestive hepatopathy if you don't have reason to believe he's volume overloaded by your exam and your point of care ultrasound.
Yeah, so the urine data in our mind trumped the ultrasound, because the ultrasound has some problems. And when you talk to POCUS experts, they'll tell you that it's often good at telling volume status, but not always. And is anybody here do a lot of POCUS and has studied that particular thing?
I do some. I know the data is very, very mixed. And
yeah, and so we believe the kidneys, and it's possible it is volume contracted, but we really didn't know. And volume contraction should not cause the liver tests.
Right.
We don't have any other good reason for his liver tests, and he did have some edema. So what would you do if you're if you're making decisions about this patient?
Oof. It's hard.
This is hard. This is hard. That's why we're presenting this one. We're not presenting it because it's easy, because we know the final answer. But we sat there and talked about it. I bored the hell out of Carl talking about it.
I guess, yeah. We do a trial of diuresis and see what happens. It feels very wrong.
Well, whenever we diuresed him, his creatinine went up.
Well, do you know that the diuresis was effective? I think one common problem we see is someone gets 3 days in a row of furosemide, but they don't make urine and their weights keep going up. And someone said the diuresis made them pre-renal, but in fact, the diuresis hasn't done anything.
Yeah. So Paul, unmute yourself and tell us, because you have an interesting comment in the chat. Tell us what you were thinking.
Yeah, so my thought is when you have we're assuming it's cardiorenal syndrome, and they're not responsive to diuretics. It's not an issue of decongestion in the heart, but they might need some inotropic support to get them over the hump. Either way, hyponatremia in a heart failure patient who's had a elevated ADH is a very bad prognostic sign, and probably is not a great picture for the patient in terms of long-term outcomes, but at least in the short term, that's probably what I've seen, at least on the heart failure services, to try and get them over the hump.
Thank you, Paul. That was exactly our thought. We first talked to Renal. Renal agreed with that assessment, that we had to figure out exactly where we were with the heart, that the heart was the center of all the activity. So we called up cardiology. At this point, what was his pro time, Carl?
At this point, his pro time had come down, got his INR written, it came down to 2.3. So still elevated above where they wanted it, but it had come down.
Yeah. So we put a little pressure on cardiology, and tell them how, tell them what happened and how the patient did.
So yeah, as Dr. Centaur was saying, cardiology wasn't too impressed that this was heart failure, and obviously for the patient's safety, we want the pro time to correct ideally to 1.5 before taking them to the cath lab. But we'd been sitting on this patient for about 3 or 4 days now, and we've just been watching his creatinine steadily increase. He'd already had trials of diuretics. We'd held his diuretics. It continued to increase. And then we had this conflicting information with the bedside ultrasound, and physical examination was challenging in this patient. So we, as we've discussed, our differential was, basically shock liver, shock kidney versus cardiorenal syndrome, hepatorenal syndrome. And then the urine studies for us and for renal and ultimately for cardiology showed that the kidneys are working, they just weren't being perfused. So after talking with cardiology, they agreed to take the patient to the cath lab despite his elevated pro time, and finally got the right heart cath, which was very helpful for this patient. So it showed that overall
Carl,
his cardiac index was decreased. Yeah.
Yeah, you're breaking up. So start over again with the cath.
Okay, so we finally take him for the cath, and it basically shows a depressed cardiac index. The fit cardiac index was 2, with a decreased cardiac output and elevated peripheral vascular resistance.
So tell them what they then did and what happened.
Yeah, so essentially this shows this patient was basically in cardiogenic shock, was not perfusing his kidneys appropriately. So we ended up transferring him to the CCU, where he was started on dobutamine with IV diuresis. And over the course of 3 or 4 days, his creatinine decreased to 2.5, which is really impressive. And he was transferred back to our service. We continued IV diuresis for 2 more days. And ultimately, the patient was able to discharge home with his creatinine still above baseline, but down to 2.3 on discharge.
And the liver tests?
And liver tests had also all come down. Prior to discharge, his AST was 269, ALT was 240, alk phos was down to 140, and bilirubin had improved as well. So basically, he was able to, after diuresing him, basically getting him out of cardiogenic shock, he was able to perfuse his liver and kidneys and discharge home, doing a lot better.
And get him on a better cardiac regimen. So, yeah. Patrick, you get to go first. What did you learn from? By the way, for someone who has not even been on the clinical service, you're a star. You did great. Very, very. I wish you were going to be my student next year. What did you get out of this?
Well, I learned quite a few things. One is a misconception I had about rhabdo. I thought it like increased your creatinine due to kidney injury, but I guess it makes sense that you're bursting a bunch of creatinine into the serum. And also learned about what the actual criteria is for alcohol-related liver injury.
Rebecca, what did you get out of this?
I think my ongoing skepticism about volume status assessment, both as a, clinically and by POCUS, but I think most notably for me is I don't know that I've ever seen transaminases that high from congestive hepatopathy. And I think, making me rethink my differential for these kind of moderate to highly elevated transaminases and still including that in my differential is probably my biggest takeaway.
Carl, it was your patient. Carl did a great job taking care of this guy. But what are the big things that you got out of taking care of this guy and the whole story and all the discussions we had?
My big takeaway was the importance of urine electrolytes. Honestly, like I had heard a lot about electrolytes and I've ordered them, and it's challenging because, as Dr. Centaur said, unless the patient's really oliguric, they're of limited value. And then oftentimes patients have either received fluids or been diuresed. And that can just basically distort the values. But the fact that this guy hadn't received fluids, we'd held diuresis, and he was oliguric, basically allowed those two values, the urine, sodium, and creatinine, and the physiology, which Dr. Centaur did a great job of explaining to our group, kind of put the pieces together about the fact that this patient's kidneys were working. He just wasn't they just weren't being perfused. And then basically, just the importance of kind of reevaluating as well. Like we had two differential diagnoses, and he had a complicated hospital course, and when we initially thought this was shock liver and shock kidney, but just reassessing and taking a step back and saying, well, he's not improving. These numbers aren't going down. Let's rethink this. What are some other likely causes? And this is a very bread and butter medicine case in many respects, and it felt good to get this guy where he needed to in the CCU. Get inotropic support and be diuresed, and then ultimately go to discharge home. Because we're worried. I mean, at one point we're worried if we had to start him on dialysis, but we were able to basically get him better. It felt good.
Yeah, and the clinical evaluation of this guy was really tricky. I mean, we had to put all stops to get cardiology to cath him that day.
I need to get better at bedside ultrasound. We still don't have a great explanation as to why we saw that collapsible IVC. But I think I've been meaning to look up data as well on how reliable bedside ultrasound is, and obviously it's very operator dependent. So,
Sean, out there in Charleston looking for a house, what'd you get out of this one?
I think a couple different things. I liked how Dr. Berger mentioned when you're evaluating a creatinine, thinking about, is this a reason to think about a false elevation? And I also kind of liked how, in basically everything that you're thinking about with labs, going back to look at the med list to see if there's a medication that could explain the abnormality that you're seeing is something that's fairly important, and something that we kind of overlook at times.
Great. Paul asked me a very interesting question. Could I make any distinction of congestive hepatopathy from shock liver? No, I don't know how to. It would be nice. I probably should get in touch with Megan Gray and ask her to answer that question. And the collapsibility of the IVC, I think this brings it into question. And I think the principle here is any one piece of information might not have a perfect sensitivity and specificity. There's nothing that has a perfect sensitivity and specificity. But the fact that the kidneys were working, that we were sure the kidneys were working at that point. Once we were sure the kidneys were working, then you had to figure out why the kidneys weren't being perfused. And fortunately, the nephrology team, and we actually went and found the nephrology team and had a long conversation with them also. And we were unified in our belief that it was really important to figure out what the heart was doing. And I think the guy did really well afterwards, and hopefully will do well in the future. And again, Carl did really great. Sean mentioned that shock would have LFTs, and LFT, I hate the term LFTs, liver transaminases, or liver enzymes in thousands. Yes, but they do come down. And so we didn't know if the transaminases had peaked and were come down, because it was 3 weeks since he had surgery. So, and was a lactate ever, did we ever check a lactate? Rebecca wanted to know if we checked a lactate. I don't remember. Carl, do you remember?
We did. We checked a lactate, right? I think over the weekend, and it was actually 1.7, so not significantly elevated.
This guy had warm extremities.
Mhm.
And anytime you went in and talked to him, he says, I want to go home. His creatinine keeps going up and he wants to go home.
Yeah, and his blood pressures were consistently in the 100s over 60s to 70s.
Not too bad for a heart failure patient.
Yeah.
We thought this was a really interesting on a lot of different levels, interpreting lab tests, interpreting POCUS. He was warm and wet, but still congested. Now this, we sort of predicted that his right heart cath was going to be abnormal, but cardiology thought they're going to do the right heart cath and send him right back to us. They were fooled, and they're good cardiologists, but then we predicted that they would either put him on milrinone or dobutamine prior to the cath, and dobutamine won out and worked real well, and he responded well to diuresis afterwards also. So I hope everybody learned a lot. We had a lot of fun taking care of this man, and any reason he went into cardiogenic shock? I don't know. Complicated post-op course.